Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Welcome to Indications. My name is Nick Strasser, and thank you for joining us. If you haven't joined us before, Indications is a platform where we talk through some of the surgical cases, particularly if you work in medical sales, but also if you work in healthcare in general. Today we're talking about a patient that's a little bit elderly. She's not very active, but has a complex problem with a distal tibia fracture that's going on to a non-union, malunion, maybe a delayed union. There's different ways we can term it, but the challenges in this case are poor bone quality, poor host, some of the challenges with fixations, and then also, as we come to find out, there's a previous total knee. So talking through the discussion on using intramedullary fixation versus plating in this particular case. So tune in. We think you'll enjoy the conversation. Hopefully get something out of it. This is just real quick, 80-plus-year-old female, multiple medical comorbidities, comes in with a distal tibia fracture, transferred in. Bethany gets asked to take care of the case. And you look at this, and I don't remember if she refused any surgical treatment, but she gets treated in a cast for a while. And Bethany, feel free to add any context to what I'm.
Well, she's a very, very minimal ambulator, like Hoyer lift mostly.
At baseline.
Yeah. So I did not want a cast. I was trying to not operate on her. She's poor host, dementia, and Hoyer lift mostly.
Just put it this way. When I was looking for pictures of the skin, there were several pictures of like a urine-soaked cast on there. So like just not very mobile. But then she has this. She has it's a total knee, same side. Question was, can you nail this? Not the fibula, the tibia. Well, maybe the fibula too. John, Bethany, what do you think? Bethany, what was your thoughts?
That's what I wanted to do. I really was going to nail it. And I asked 3 of my trauma partners and they all said no. They said the canal was very capacious. It was ghost bone. It wasn't going to hold up and I should plate it with a subcutaneous or extraperiosteal medial plate. So that's what I did.
Jahangir tell you to plate this?
Jahangir's in a lot of administration these days. So no, I didn't. He might have not been one of the ones I asked.
Jan, what do you think? I mean, there's obviously, it sounds like it wasn't even the previous total knee. It was the ghost, like bad bone quality, big canal, limited ability to get fixation distally. What are your thoughts on that?
I mean, it sounds perfect for a nail.
Great.
I mean, I think we do it for like the proximal femurs. We do it for distal femurs. The poor bone doesn't stop me. I mean, if you're going to operate, I would nail this, I think.
And then what are your strategies for managing it? Those issues?
Yeah, so I think distally, I mean, like this is something I would clamp or open reduce if I couldn't get it, and then put a nail in. I think you could do a standard nail here. You don't have to worry about, like, you have plenty of space in front of the keel on the tibia, on the lateral. So, and then I would load it up distally with screws. So I'd use 3 or 4 screws distally, maybe a blocking screw or stability screw, just to kind of tighten up the canal a little bit, like a cortical substitution screw or 2.
Or 7.
Yeah, I mean, whatever.
Yeah,
I mean,
all the
like
way
how
up.
many you can put approximately distally, whatever you want. I mean, just to make it a little bit more rigid.
And then this is different than a suprapatellar nail, obviously, because you're wanting to stay out of that joint. So you're doing this like with the standard nailing.
Yeah, I would do this in a standard nail. I would not go through the knee, even though I do it all the time for retrograde nails or the femur. For this, I would not do an antegrade nail. I would do an antegrade nail, but I would not go suprapatellar. I would stay extra articular here.
All right. So then gets treated non-op. Probably just, it sounds like, I mean, for all the reasons that were already mentioned. And this is at 2.5 months. Bethany, I don't know if you have any context as to what decision to fix it or not, or at this point,
it had a little bit of drift and it was just very minimal callus more than anything. So I offered to fix it.
So went ahead and fixed it and used a medial plate like we had kind of talked about. So fixed the fibula in this case, used a plate on the fibula, and then approached it through a medial incision. It sounds like a MIPO or a minimally invasive approach on the medial plate.
Any use of biologics here, Bethany?
I think I might have put a little DBX in there, but
Are you a fan of BMP or infused?
No, no, that's not. I'll be honest, I don't use BMP out of the gate.
Okay.
So a little bit of bone graft into there, and then slid the plate medial, or from the medial side, slid it up, I'm assuming, and then with distal fixation and clamped it with leg through the plate and then final fixation here.
Yeah.
And overall looks, this is maybe 2-3 months, maybe not even post-op. You see all the calcification from the vessel like right in the middle of the leg.
Look how bad that bone. Look, that calc has disappeared.
Yeah, it's wild. But it looks good. I mean, it looks like it's healing and it looks well aligned. It's not drifting.
I mean, she doesn't really walk on it, so.
Did you
should
put
be
her in a cast or splint, or did you let her go
forever.
forever?
Cast forever.
That's